part 2. All right, really, really important for you to know the difference between Kappa and septal hematoma. Kappa, as I mentioned, is just generalized swelling, and it will dissipate in a few days. Septal hematoma, there was an active bleed. Maybe nothing more than a big bruise, but still, it's a hematoma. All right, so we have to watch that a little more closely just to make sure that it's resolving. It's not growing larger, that it is either staying the same or getting a little smaller. Another concern is it will take longer to resolve. The lump, if you will take longer than Kappa, which is will just dissipate much sooner. The septal hematoma is a bunch of red blood cells that need now to be destructed, all right? So there's extra red blood cell destruction for that newborn. Red blood cell is broken down into bilirubin. And increased bilirubin, it will cause jaundice. So a baby with a septal hematoma is at a higher risk for jaundice. Does that make sense, how it breaks down? So that's why it's so important to know the difference between Kappa and septal hematoma. As I mentioned, all babies have a pink tinge to their skin. You just might have to look a little harder to find it on darker skinned babies. But a pink tinge kind of makes us know that they're well oxygenated. Acrocyanosis is what that bluish tint to their hands and feet is considered. All right. Circumaural cyanosis is actually when the blue tint is around their face, around their mouth. That's not so good. But blue tint to their hands and feet is pretty common, especially within the first 24 hours or so. They could just be a little chilly, like following their bath, and their hands and feet could turn blue again. Perfectly normal in the first 24 hours or so, all right? If you and I got cold and our hands turned blue, that's really, really cold. But it doesn't take that much with a baby, all right? You might see mottling on a baby, and that's just the lacy pattern of blood vessels you often see like on their chests. They're dilated blood vessels, and they're so close to the skin surface that you might be able to see the whole network. Other marks that we might see, or skin issues, desquamation is that cracked peeling skin of the post-mature baby or post-term. Other marks, Mongolian spot. A Mongolian spot is this bluish tint, often seen on the buttocks or thighs of a baby. More common in the darker skinned baby or the Asian baby. It means it's completely benign, but it's so very important to document. Why do you think that is? Could be abuse, right? Well, a baby just coming out with bluish tint, a bruise-like mark on their butt is probably not suspect. But 2 weeks later, when they go to the pediatrician and a nurse or doctor sees this bruise-like mark on a newborn baby, they're going to go back to the initial assessment from the delivery, and they better see Mongolian spot noted on right buttocks, or they're going to suspect that that's a bruise. So that's why it's so important to document when we see it, not because it has any clinical significance, but it can have a social significance later on by a prudent caregiver. Stork bites, or this big fancy word here, it's just like a reddish mark, often seen on the back of the neck or like between the eyebrows, or sometimes you'll see them on an eyelid or something along those lines. Again, completely benign. They do fade a bit with age. A baby. Newborn baby, it might be on the dark side, and as they just grow older as a toddler, it'll fade. But when they get mad or they get upset, it like flares back up again. You can tell what mood they are in. It's in this stork bite coming along. Ooh. Avoid that, toddler. Erythema toxicum. Erythema toxicum is these little flea bite looking marks, all right? Completely benign. It's just the skin's reaction to the outside world. Just think this kid was protected with amniotic fluid and everything. Didn't have contact with anything. Now we're rubbing it and it's going up against chemicals and fabrics and all that stuff. It's just a little irritation, a little the natural response in a newborn. This is important to tell mom and dad about because they're going to think that there's some sort of either a serious rash, something that they should try to pop because there is like a little yellowish center to it, or something they're going to accuse the nursing staff of having fleas in the hospital. I will tell you, one night, Dad was not there for the exam of the baby, and we talked it over with Mom, but the baby got a little of this erythema toxicum, and that dad, who had been out celebrating fatherhood apparently, came in at like 2 o'clock in the morning, took one look at his kid, and came racing out to the nurse's station like, "This blasted hospital has fleas," and we were like, whoa. It's because he thought his kid was getting flea bites. That's not a great thing, even if it's a 2-minute thought process for that dad. All right, so it took a little while and some internet pictures to show him, look, this is what it is, it's normal. You know what I mean? That's where patient education comes in. Even if it's just a brief moment of panic on the parent, new parent's part, if we can avoid it by just telling them what is normal, all the better. So erythema toxicum, flea bites, little yellowish raised centers to it. Milia are exposed sebaceous glands you see on the little baby's nose. They are not whiteheads. Do not put a Biore strip on the child. Do they make Biore strips anymore? Yeah. Don't do it. All right? Just exposed sebaceous glands. They will go away. Then you have your birthmarks. The port wine stain you often see on the face there, not of clinical significance, but of emotional significance. This is something we might not know ahead of time. And when a baby's born with a big, burgundy spot covering a good portion of their face, parents can be upset, right? And we have to just let them be upset. They will eventually, it'll become part of who that baby is and even cute. But in the meantime, it was something they weren't expecting, and it feels like a defect because it's on their face. I don't know. Allow them their moments of grief, if you will, and reassure them that there's no clinical significance to it after they've processed through the information. A strawberry mark actually does look like the skin of a strawberry. Even has the little, the skin pores, even like little hairs coming. It looks like somebody took and sliced the strawberry, against the outside skin of the strawberry and put it on their baby's body. I don't know who would do that. So most likely it is a strawberry mark. Maybe they're having shortcake or whatever. I don't know. Some slipped. I don't know. Strawberry mark. Perfectly benign. Where's their nose in the whole scheme of things? Is it where it's supposed to be, right here in the center? It's sometimes, have you ever seen a dad or a mom, or even one of ourselves, right? Like got a big honker on them. You're like, oh gosh, I hope their baby did. And then you see the baby, it's just like a mini honker. It's like, ooh, got dad's nose. They're so cute. I think baby noses are so cute. Anyways. So they vary based on their family, by all means. But it should be, centered in their face. Both nares need to be in patent, right? The way we do that is we block one, find out if they're because they tend to be nose breathers. So block one, and if this one's, they're going to gasp and not be able to breathe very well. Block them, figure it out that way. Their mouth, cute little lips, right? Make sure their tongue is appropriately sized. Oftentimes we can see a baby has a tongue tie, which is the frenulum underneath the baby's tongue. Is just excessively attached to the bottom of their mouth, which can create problems with feeding, especially particularly breastfeeding. And later on, if it's extreme, it could, I guess, affect speech. The other thing, Epstein pearls are, they look like a tooth about to emerge from the gum. It's not. That's just a normal kind of finding that we note, but I don't think it has any clinical significance. We also want to take a gloved pinky and put it in the baby's mouth. It certainly will assess their suck, which should be pretty strong when you put a gloved pinky in their mouth. But in the meantime, we're also feeling the palate, all right? The hard palate and the soft palate. It's really, really important to go all the way back, and then you'll also be able to assess their gag reflex. You want to go all the way back and make sure that it's intact, because a minor cleft palate, way in the back in the soft palate, might go unnoticed at first until baby's eating and it's all just shooting out the baby's nose. Right? And then we might suspect something at that point. In fact, I don't remember if it was with students or if it was on my own shift at Griffin. I had a baby who was doing a lot of spit up out of his nose, just a little bit more than mom was bottle feeding. And God bless you. And the baby was just, I don't know, just had a lot of spit up out his nose. And I went and I reassessed their palate, because I'm thinking, why is there so much coming out of this kid's nose? His palate was fine, but we just got to make sure. I mean, shame on us if we miss a cleft palate. It can affect breathing, and we don't want there to be any aspiration or anything like that. And it can certainly affect feeding. There are special bottles and feeding tools, if you will, for babies with cleft palates until they can be repaired. The neck should be short and thick with no webbing. They should have full freedom of movement, range of motion, really. And they do actually have some head control. The chest should be barrel-shaped. Nipples and breast nodules should be present in a full-term baby. There should be easy breathing. We also check their clavicles, because especially if it was a real tight fit, some newborn babies have fractured their clavicle, and they're not going to tell you, hey, my arm really hurts. So we would feel for crepitus. It's like feeling like Rice Krispies underneath. It always gets me a little when I actually feel it. I haven't felt a fractured clavicle in a long time, but we certainly want to find it if it's there. What do we do for a fractured clavicle? Not much. We can't do much for an adult with a fractured clavicle either, except listen to him whine. But we may just note right clavicle fracture, so we're not picking the baby up in a way that would jostle it. Some doctors want some limited movement of that side, so we have those long sleeve t-shirts newborns wear. We might actually safety pin the right or left sleeve to the opposite side, kind of making it a sling. Other than that, there's not a whole lot we can do. They may, if they feel like it's very extensive, x-ray and follow up with orthopedics if they feel like it's really misaligned or something. But their cord, their abdomen, their umbilical cord should have 2 arteries and 1 vein. You should hear baby gurgles, little baby bowel sounds there. 2 cords and 2 arteries and 1 vein. I remember that by knowing that the arteries are more rigid, and they retain their more circular shape when you cross-section it. So like when you cut the cord and then look at the cord, you'll see the arteries that are still round, whereas the vein is collapses, and it's usually a straight line. So it reminds me of the meh emoji, you know, the eyes with the, so now you're welcome. 2 arteries, 1 vein, all right? We're going to listen to the heart rate, listen for the rhythm, murmurs. We're going to assess brachial and femoral pulses. They're doing it, you should do it in a couple of different ways. The first way I do it is bilateral for like both the femoral and the brachial. We want to feel them both at the same time. Because, why? Yeah, we kind of want them equal. If one's like really bounding and one is very weak, we worry about circulation, right? If you want to measure the one-sided, both on that side, you'd expect also the brachial and the femoral pulses to be equal in strength compared to each other, okay? There, it's not as good a picture as the meh emoji, but you got my point, right? Meh. I should add a slide there. I should. Somebody, make a note of that. All right. We'll check out their hind end, the down belows, as I say. We want to make sure the urinary meatus is at the tip of the penis. If it's lower, we call that hypospadias, and it may have some clinical significance. The labia should be covering the clitoris. Some newborn girls have a little vaginal discharge. Some babies, within the first 24 hours or so, might pass some uric acid crystals in their urine. Pretty common in the first 24 hours. Here to tell you, uric acid crystals looks like a pink powdery substance. Me as a new nurse thought it was blush. Looks like blush. I was horrified because somebody clearly was putting on makeup while changing the baby's diaper, and I didn't think that was appropriate. Who on earth dropped blush in this baby's diaper? No, Libby. It's uric acid crystals. I'm just telling you so that you learn from my mistakes and don't actually become outraged when you see that, if you were to ever see it. Save the embarrassment. I took care of it for you. No, you watch. When you see it, you're going to think, oh, that really does look like blush. That young Libby, that youngster nurse Libby, wasn't completely crazy at the time. There should be full range of motion and flexibility of the extremities. We would expect the natural state of a newborn baby's extremities to be flexed, okay? It's nature's way of protecting their bodies and keeping themselves warm, all right? You turn them over and look at their cute little butt. Their cute little butt should be, their gluteal folds should be symmetrical. It should be even on both sides. If one was much lower than the other, we would think maybe there is a placement issue. Their hips might be displaced, all right? We're going to check their hips for clicks, and we'll go through some maneuvers on that. And count their toes and their fingers, right? It should be 5 on each hand and feet. Funny story. When you're in the OR, actually now in the vaginal delivery room as well, but in the OR there's lots of counting of sponges and whatnot, right? Well, mom and dad baby was born, they were over, they could hear the staff counting 1, 2, 3, 4, 5, and they're like, oh, they're counting toes and feet, and then they got past 10, and they were like 11, 12, and they're like, whoa. They thought something was drastically wrong. In fact, they were counting sponges, not toes, so. Nonetheless, there should be 10 total of each. The spine, we want to look, make sure it's straight and in midline and intact, all right? Sometimes we might see a little dimple at the base of the spine, right above the buttocks. Don't want to mess with it, all right? We don't want to go poking in there because that could be just a very subtle opening into the spinal, like a spina bifida, all right? Particularly if there's a dark tuft of hair coming out of that dimple. That's a pretty strong sign of spina bifida. Back to the genitals, the 2 points that I think are pretty interesting. First is that newborn baby girl has a complete complement of eggs for the whole rest of her life already in her ovaries. That's pretty cool. I think, anyways. Also kind of interesting, although alarming for some to see, that baby was being given all the hormones mom was being given, right? In utero. Baby's born, and now we have an abrupt withdrawal of estrogen from mom. And so some newborn baby girls will actually have a pink tinge discharge, we call it pseudomenses, because of the abrupt withdrawal of the hormones. Pretty cool, huh? Their labia, both majora and minora, are often a little puffy, a little edematous. That's normal as well. So, testes. 90% of term male infants will have both testes descended into the scrotum, all right? The scrotum should, in a full-term baby, should have the ridges, we call them rugae, however you want to pronounce it, all right? That is the sign. That's actually probably part of the gestational age assessment, both the testes descended and the rugae on the scrotum. Phimosis is the tight foreskin. That's pretty common as well. And as I mentioned before, hypospadias is when the urinary tip is a little bit lower on the penis. It might not mean anything, or it might need repair. These babies are not circumcised in the newborn nursery, and it was just, I want to say 4 years ago, that I finally had the courage to ask, why not? Like, why? What does circumcision have to do with hypospadias? And they're like, nothing. It's just we might need the foreskin for the repair. They might use the skin of the foreskin for the repair. Oh, cool. After 30 years, I finally asked. Made perfect sense. I didn't know. All right, the hip dislocation. We do these two maneuvers, if you will, the Barlow's maneuver and the Ortolani's maneuver. The Barlow's maneuver is, do you see this baby up here? We're going to, undiapered baby, we are going to, I place these two fingers on their hips so I can feel their hips. And the other hands, I bring their legs, bend their knees, bring their legs kind of up towards their belly, kind of push down and rotate out. And then you rotate them back in for the Ortolani's maneuver. If there's a congenital hip dysplasia, you will feel and maybe even hear the dislocation that you cause by doing that. It'll be a clunk feeling. I have to tell you, that's not a pleasant feeling, nor is, I imagine, very pleasant for the baby either. But it's the Barlow's and then the Ortolani's movement. So a positive Ortolani's or a positive Barlow's sign is not good. We don't want that. That would be indicative of a hip dislocation. My wife had bilateral hip dysplasia, but nobody saw it, nobody noticed it. She was 35 years old having bilateral hip replacements because of a lifetime of dislocating her hips. And they had worn down, they were completely damaged. And her whole back is all screwed up because her hips kept dislocating, and she was in a lot of pain. They thought it was back pain, but it was some smart doctor out in California, when she finally could hardly walk, said, let me check your hips. And the acetabulum of her femur were like completely destroyed because of all the dislocating and rubbing of the. Yeah. Somebody asked, well, how did they find that? And I said they laid her down and they these two maneuvers, which they did not do. I just think that'd be pretty funny, laying an adult down to try to do that. They did not. I'm sorry, Julie, in case you're watching. X-ray, probably, at that point, the older. All right. Anyways, let's look for club foot as well. It's not all that obvious necessarily at first when they're all scrunched up and cute, but it's something to note in the chart, maybe followed up by some orthopedic consult. At back, we are going to look at, make sure it's nice and straight and right in the center of their back, their spine. The gluteal folds should be symmetrical, as I mentioned before. And again, looking for dimples and tufts of dark hair, not good. Don't go poking around. They might do an ultrasound or something like that to see if that dimple is intact. We want it to be nice and intact, but at the base of that dimple could actually be opening right into the spinal canal. So that's why we don't go poking around to find out.
Does that stay all their whole life, or does that go away?
It would probably require repair. The dimple itself, I don't know. Does anyone have a dimple? Anyone? Nobody wants to admit or show us? No? Is that what you're talking about, the dimple? I don't know. I think there's probably always like a little bit of an indent, maybe. I don't know. I don't really know anything about any human beings past the like 3-4 week mark. Just as foreign to me as you. Maybe even more so. Once they start walking and talking and asking questions, I'm like, whoa. Who are you? And where's your mommy? That's Robin's world downstairs. Anyways, reflexes. Reflexes are my favorite. Well, I mean, you already know I'm weird, so this will just confirm that for those who are unsure. Reflexes are pretty cool, if you ask me. Nature gives us a set of reflexes to protect us and to help us, all right? The sucking reflex, pretty important to know how to do, right? The rooting reflex, if you brush the cheek lightly, a baby will turn and open their mouth to whatever is brushing their cheek. Preferably a breast nipple or a bottle nipple. You know, that'll initiate the sucking reflex. The palmar grasp, if you put your finger lightly on a baby's palm, they will grasp whatever's in their hand. Oh, look, the baby's holding my hand. Just go with it, all right? You can, well, actually, what that is showing is your child is neurologically intact. Yes, the baby loves you. All right, just go with it. But do know that's a reflex. Just as cute is the plantar grasp. While they don't completely encircle the finger that's lightly touching them on the sole of their foot, you will see the toes curl down kind of around the finger, which is kind of cool. The opposite of plantar grasp is the Babinski, which, if I could have a favorite, that is my favorite reflex. You lightly run your finger down the sole of the foot, and the toes should splay out. So on those long nights of night shift in the newborn nursery, I would plantar grasp, Babinski, plantar grasp, Babinski. I got really good at them. Tired the kids out. The Moro reflex and the startle reflex look kind of the same. I mean, the end result is the same. The stimulus that created them, if you will, is different. The startle reflex can be a sound, a sudden like tap of the bed, the mattress, something like that. They're like, yeah. That's what this is, kind of out and around like this. Whereas the moral reflex, you're actually holding the baby's hands and you kind of lift them up and gently let them go, and they'll do the same thing. They look the same after being stimulated. The stepping reflex is cool. The stepping reflex, you hold the baby unencumbered, like no diaper or anything like that, upright, with their feet touching a flat surface, and you move them a little bit, and it looks like they're actually walking. All right, some call it the dancing reflex. I'm here to tell you, they will not support their own weight. All right? Just don't do it. It does look cute, though. Another favorite of mine is the tonic neck reflex, or the fencer position. If you put the baby's arm up like this on one side and straight out that way, they will turn their head this way, as if fencing. The more advanced babies will actually lunge and say on guard, but those are quite advanced, so you wouldn't expect that. Yeah. So your baby did.
Absolutely. When our son was born and they did his starter reflex in the hospital, he doesn't remember this, but I do. It freaked me out.
Mm-hmm.
They actually held him and did a fake drop, held him over a thing, picked him up slightly, and just did a false drop. It was
Wow.
the pediatrician that did it, not the nurse.
Yeah, would expect that. Yeah, yeah. Oh my.
Freaked me out.
Yeah, and I bet you it kind of freaked baby out too. Yeah. Oh, that's not nice. No. So there's the moral or the startle. We're not really sure. And here's their stepping or dancing reflex. Bunch of different reflexes. There's my Babinski. There's the moral. Plantar grasp, the sucking, and the rooting. Vision. A newborn can focus 9 to 12 inches from their face, which is really convenient because when you're holding a baby, what's 9 to 12 inches from their face? Well, the boob actually is probably a little closer than that, but your face, right? Your eyes. So it's great. It's perfect distance, I think, to make eye contact with your own baby. Hearing, actually similar to an adult's hearing once the amniotic fluid and everything gets out of their ears. All right. We do a hearing screening on every newborn baby before they leave the hospital. It's actually, I believe, state mandated in the state of Connecticut, anyways, and most states now do it. We try to wait up to 24 hours to get that fluid out of their ears. No matter how many times you ask them to raise their hand. You remember in school they put the headphones on? You just sit there and be like, raise your hand to the sound on. You're like. It always stressed me out. Well, it stresses newborns out. They will not participate in any way, shape, or form. So they do something with brain waves, and I don't know what they do, but it's much more definitive and not stressful at all, apparently. So that's that. Touch. They do respond to touch, tactile messages of pain and comfort. Sorry over there. They will, I don't know, some people saw me with my tactile touch. I can get most newborn babies to stop crying within 10 seconds. I don't know, I have this little spell. Do that 9 to 12 inches from their face. It's a touch thing. I don't know what I do. But I can get a baby to stop crying pretty quick. It's their response to touch, mostly, or magic. We're not sure. And you think, of course a newborn responds to pain. Isn't that just obvious to everyone? Well, guess what? 30 years ago, in the newborn nursery, I was setting up circumcision tables, or whatever, down the line, 6 babies, boom, 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 all getting circumcisions at the same time in a big, busy nursery. Not one bit of pain medicine went into those kids. No numbing, no anything. We strapped their arms and legs down to restrain them because you don't want them, kicking the doctor, we don't want them kicking the doctor. And they got their circumcision. You couldn't tell me that they didn't experience pain, but the general consensus is that they didn't feel pain. I'm not sure who came up with that theory. Shortly after, we started saying, you know what? There's a whole lot we can do to at least keep them a little more calm, because initially they were just pretty pissed off that they were naked and strapped to this plastic board, right? So we started saying, well, we need to restrain and hold their legs down. Do we need to hold their arms down? Let's swaddle them on the top and just keep them a little bit more secure feeling, anyways, emotionally. So we started doing that as a nursing community. And the doctors didn't have a problem with that. Their legs were still restrained, so we were good, right? And we thought, let's comfort them with, sucking on my gloved pinky, all right? The sucking reflex helps to comfort a baby. So these are the things the nursing staff were doing, and we were finding that we were able to get some babies to relax during a circumcision that way. Then finally, somebody says, you know what, I bet this hurts. So we should do something about it. So they started doing like a Emla cream or a topical numbing, which has limited success, and not all doctors agree with its benefits. And then they started doing the penile nerve block, which is an injection of lidocaine on either side, or bupivacaine, on either side at the base of the shaft. Supposed to wait 5 minutes, and then doing the circumcision at that point. We're also giving babies what we call sweeties or toot sweets, which is 20 or 30% sucrose. It's not sweet to any of us, but to them it's sweet. And that amount of sucrose does something chemically that helps divert the pain signal. Some hospitals, like I know Manchester, give a dose of Tylenol to the baby post circumcision. And they do have Tylenol ordered every 4 hours if a baby appears to be uncomfortable. There's a newborn infant pain scale that we assess, and it's all about cry and rigidity, and there's a couple of different things that we are, because they won't tell us I'm in pain, but they will show us that they are in pain if we're looking. So it wasn't that long ago when we were not acknowledging pain in a newborn. 9 out of 10 babies surveyed prefer sweet over salty, sour, and bitter taste, as well as sweet smell. I don't know how they figured this out. Cooperative babies, maybe a written survey post-discharge, I don't know. Nonetheless, there's their preferences. In terms of smell, which I think is really cool, a newborn baby can recognize the smell of their mother. That's pretty cool. Has anyone seen the little video of the very smart father who was taking care of their newborn baby, and because mom had to go away for the day or whatever, baby would not settle down. And then dad gave the baby mom's shirt or t-shirt or something like that, and the baby immediately smelled mom and settled down. I think that's pretty cool. So a newborn baby can recognize the smell of mom. And imagine after a time can recognize the smell of dad too. It's just, I guess, mom being a little bit more immediate, having grown inside her body. Maybe that's why. So we got to make sure baby's doing it right. So we're initially, because of all the changes, we are going to do vital signs every half an hour every hour for a couple more hours, and then every 4 to 8 hours after that in a normal, healthy newborn. All right. Naturally, if they're having trouble with any of those, particularly temperature seems to be the one that they have trouble, we're going to take them more frequently. If we're worried about infection that maybe mom was brewing, we would take baby's vital signs more frequently just to make sure baby wasn't getting infected. All right. We do a daily weight on a baby. We try to do the same scale, same time of day. If a baby's only 24 hours old, their daily weight is 4 hours earlier or later on the second day, that's an eighth of their life. That's a long period of time difference, all right? So we try to do it around the same time each day, so we can say it's truly a weight every 24 hours. The same scale is important because some scales could be different, by, 100 grams or so. Well, if a child is only 3,000 grams, a couple hundred grams difference simply from the scale to scale could be significant as well, right? We don't want a newborn baby losing more than 10% of their weight. But we do expect them to lose some weight initially because they're full of poop and they're not taking in as much as they're giving us in terms of poop. So a slight weight loss is common. All right, just so we want to keep it less than 10% of total weight. We're gonna just observe their umbilical cord for drying and signs of infection. Back in the day, we used to use a triple dye. It was a very messy process. At the end of the day, depending on how many admissions I had, you could tell by how dark my fingers or the blue splotches on my white pants, because that's what we wore back then. We used this, it was dark and like purple blue color. Dye had antibiotic properties, I guess, I don't know. Couple years in, during my time, we went to rubbing alcohol. So we would just use isopropyl alcohol on the cord itself just to keep it clean and to initiate or to facilitate the drying of the umbilical cord. Studies done found that it did not decrease risk of infection. It did not increase rate of drying, but it certainly broke down the skin around the umbilical cord. So we stopped doing the rubbing alcohol as well. And so now all we do is we keep it open to air. We want the diaper lower than the umbilical cord. And we just watch it. We just watch for drying and watch for any drainage and make sure the skin around the belly button remains intact. All right, a baby is born and initially is like, whoa, what just happened? And is like wide awake, looking like taking it all in, all right? Great time to take the baby away and like bond with the baby, right, as a nurse? No, keep the baby with mamas and the daddas, right? That's who should be keeping eye contact with the baby. If we can, that's a great time to initiate bonding with the parents, is when the baby's nice and alert and like gazing into his mom and dad's eyes. That's great stuff. Following that initial 15 to 30 minute reactive period, the baby tends to fall asleep and can be pretty drowsy, like very hard to wake up because it's been a rough morning, right? I've just done a whole lot. So a period of inactivity, if you will, relatively, for a couple hours, and then it follows with another period of reactivity, all right? So plan things out accordingly, all right? The first initial reactivity, we want mom and dad to be the main holders of that baby at that time. Maybe during the less active period, maybe that's when we can do some of the assessments and stuff on the baby at that point. Also, during the reactive periods is probably when we should initiate breastfeeding. If the baby's out cold sleeping, probably not going to be a very successful first attempt if that's when we're going for it. See where that can help. All right. So use the periods appropriately. There's very few lab tests that we do on a newborn baby. All right. We might get a hemoglobin and hematocrit on a newborn baby if we're concerned about any bleeding. Maybe I don't know. It doesn't happen very often. We might test the baby's blood glucose, which is just like a finger stick, but we do it on the baby's heel. Exact same machine, everything's the same. It's quite slightly smaller lancet that we would use to get that. We would expect a newborn baby's glucose, full-term baby, most now is above 45. 45 for a normal blood glucose. It used to be 40. Now some places are even going to like 50, but 40 to 50 above that. Preterm baby, normal glucose is above 25. The baby's at risk, yes. Thank you.